Hello, dear student. My name is Irina, and I'm your lecturer for today. And we continue gastroenterology tract and discuss about dyspepsia and chronic gastritis. So let's start. Dyspepsia symptoms include a constellation of upper gastrointestinal complaints such as belching, postprandial fullness, early satiety, epigastric pain, and epigastric burning. Functional dyspepsia is diagnosed when an organic etiology for the symptoms is not identified. Dyspepsia is secondary to organic disease. Although there are several organic causes for dyspepsia, the main causes are peptic ulcer disease, gastroesophageal reflux, medication, and malignancy. Also, gastric cancer as a causes of dyspepsia is concern for both healthy care providers and patients. It is uncommon in North America. Peptic ulcer disease. Upper abdominal pain or discomfort is the most prominent symptom in patients with peptic ulcer. Although discomfort from ulcer is usually centered in the epigastrium, it may occasionally localize to the right of left upper quadrants. While classic symptoms of duodenal ulcer occur when acid is secreted in the absence of a food buffer. Peptic ulcer can be associated with food-provoked symptoms, and thus the utility of using symptoms related to food ingestion to predict the presence of an ulcer is unreliable. Peptic ulcer can also be associated with postprandial belching, epigastric fullness, early satiation, fatty food intolerance, nausea, and vomiting. Gastroesophageal malignancy is an uncommon cause of chronic dyspepsia in the Western Hemisphere, but the incidence is high in patients of Asian, Hispanic, or Afro-Caribbean extraction. The incidence of gastroesophageal malignancy increases with age. When present, abdominal pain tends to the epigastric vague and mild early in the disease, but more severe and constant as disease progresses. In addition, other symptoms and signs typically evolve with disease progression. Biliary pain. Classic biliary pain is characterized by episodic intense dull pain located in the right upper quadrant epigastrium or substernal area that may radiate to the back. The pain is often associated with diaphoresis, nausea, and vomiting. The pain is constant and not colicky. It is not exacerbated by movement and is not relied by squatting, belching, bowel movements, or passage of flatus. The pain typically lasts at least 30 minutes, plating within an hour. The pain then starts to subside with an entire attack, usually lasting less than 6 hours. Drug-induced dyspepsia, non-steroid anti-inflammation drugs, and cyclooxygenase 2 selective inhibitors can cause dyspepsia even in the absence of peptic ulcer disease. Other drugs then have been implicated in drug-induced dyspepsia include calcium channel blockers, methoxantine, alendronate, orlistat, potassium supplements, acarbose, dabigatran, iron, vitamin D, selective serotonin reuptake inhibitor, sildenafil, and certain antibiotics, including erythromycin. Other causes. Celiac disease and chronic pancreatitis may rarely present with dyspepsia alone. Other rare causes for dyspepsia include infiltrative disease of the stomach, diabetic radiculopathy, metabolic disturbances, hepatoma, steatohepatitis, celiac artery compression syndrome, superior mesenteric artery syndrome, abdominal wall pain, and intestinal angina. And some information about functional dyspepsia. Functional dyspepsia, or another name, idiopathic or non-ulcer dyspepsia, requires exclusion of other organic causes of dyspepsia. It is defined by the presence of one or more of the following: postprandial fullness, early sedation, epigastric pain or burning, and no evidence of structural disease to explain the symptoms. The pathophysiology, diagnosis, and management on functional dyspepsia are discussed in detail separately. Functional dyspepsia is defined by a Rome 4 criteria and subclassified into postprandial distress syndrome and epigastric pain syndrome. And what is it, this Rome 4 criteria? Presence of one or more symptoms of postprandial fullness, early satiety, epigastric pain, or epigastric burning, and no evidence of structural disease that could explain the symptoms. So, what is postprandial distress syndrome? Postprandial fullness of early satiety 3 or more days or week for the past 3 months and onset more than 6 months before diagnosis. And what is epigastric pain syndrome? Epigastric pain and or burning 1 or more days or week for the past 3 months and onset 6 and more than 6 months before diagnosis. And postprandial syndrome are met in 38% of patients, and epigastric pain syndrome meet in 27%. And symptoms for postprandial distress syndrome: early satiety, bloating, nausea, vomiting, and decreased appetite. And symptoms for epigastric pain syndrome: epigastric pain and epigastric burning. But you may meet overlap postprandial syndrome and epigastric pain syndrome, and meet in 35%. And etiology of functional dyspepsia: gastric neuromuscular dysfunction. Gastric neuromuscular dysfunction include delayed gastric emptying, impaired gastric fundus relaxation with blunting of postprandial accommodation, and altered gastric mechanosensitivity has been of particular interest in this area. Next etiology fact: psychological distress. Psychological distress has been associated with dyspepsia, with research showing both then distress and anxiety can precede symptoms, and that symptoms can induce distress and anxiety. Thus, bidirectional gut-brain pathway mechanism has been proposed. And next etiology fact, duodenal acid exposure, dysmotility, and inflammation. There is preliminary evidence concerning the presence of increased postprandial duodenal acid exposure in functional dyspepsia patients with prominent nausea symptoms. In addition, duodenal motility and bolus clearance impairment have been induced by instilling acid into the duodenum, raising concern that duodenal acid-driven pathology may contribute to dyspepsia symptoms in a subset of patients. There is growing evidence regarding the role of duodenal inflammation and duodenal eosinophilia in functional dyspepsia. Duodenal inflammation and in particular duodenal eosinophilia have been seen in up to 40% of patients with functional dyspepsia. And alarm future for patients with functional dyspepsia. Unintentional weight loss, new or progressive dysphagia or dinophagia, persistent vomiting, unexplained iron deficiency anemia, palpable mass or lymphadenopathy, family history of upper gastrointestinal malignancy, childhood span in country with high risk for gastrointestinal malignancy. Diagnostic evaluation. By definition, functional dyspepsia is diagnosed in the absence of an agonic etiology for the dyspepsia symptoms. As outlined previously, patients with functional dyspepsia report a range of symptoms that can vary greatly in severity, and symptoms are not a reliable way to differentiate organic from functional dyspepsia. Thus, the goal of evaluation is to rule out organic etiologies for the patient's symptoms. Evaluation is based on patient age, presence, alarm future, severity of symptoms, risk of malignancy, and physical examination findings. Patient under age 60 years without alarm future should undergo Helicobacter pylori testing via stool antigen testing or urea breath test, followed by treatment and eradication confirmation if testing is positive for active infection. It is important to ensure that patients undergoing testing do not take a proton pump inhibitor for 4 weeks prior to testing, as PPI use can cause a false negative test resulting. And treatment. First of all, Helicobacter pylori eradication. Although Helicobacter pylori-associated dyspepsia is not technically considered under the umbrella of functional dyspepsia, Helicobacter pylori infection should be treated and confirmation of eradication should be performed if clinically indicated. Helicobacter pylori infection is identified in approximately 5% of dyspepsia cases. Second step, acid-reducing therapy. PPI therapy is considered first-line therapy for functional dyspepsia. However, studies have shown PPI therapy to be effective in treatment functional dyspepsia in only 15% of patients. Next, neuromodulators. If PPI therapy is ineffective or provides inadequate relief, guidance by the American Colleague of Gastroenterology and the Canadian Association Gastroenterology recommend a trial of neuromodulator medication. Prokinetics and fundus relaxant therapies. The effectiveness of chronic prokinetic agents to treat functional dyspepsia is unclear. The potential benefit of prokinetics has supported by a meta-analysis that demonstrate benefit with cicapride, domperidone, and itaprid therapies. And psychological therapy. 58 patients with functional dyspepsia were randomized to either medical therapy alone or with psychotherapy, with great improvement in dyspepsia-related quality of life scores in the combination therapy group. And you may see picture with functional dyspepsia treatment algorithm. What you may provide. Helicobacter pylori testing. If you get positive result, treat and assess response. If you get negative result, next step after Helicobacter pylori testing, consider a 4-week trial of a moderate dose proton pump inhibitor. If you get poor response, continue and consider Hebel of neuromodulator therapy. If you have again poor response, continue and consider prokinetic or fundus relaxing agents. And return to positive result in Helicobacter pylori testing, and if you get absence or incomplete response, you need to try consider 4-week trial of a moderate dose proton pump inhibitor. So again, the best treatment for functional dyspepsia is a moderate dose proton pump inhibitor. And continue. And next part of today's lecture is chronic gastritis. The term gastritis was first used in 1728 by the German physician Georg Ernst Stachel to describe the inflammation of the inner line of the stomach, now known to be secondary to mucosal injury. In the past, many considered gastritis a useful histological findings, but not a disease. This is changed with the discovery of Helicobacter pylori by Robin Warren and Barry Marshall in 1982, leading to the identification, description, and classification of a multitude of different gastritis. And you see the Sydney system for classification of gastritis. And you may see activity for gastritis, chronic inflammation, granular atrophy, intestinal metaplasia, and Helicobacter pylori density. And it incorporates etiology, topography, and the morphological feature to be documented when reading and reporting endoscopic gastric biopsies. The topography of gastritis in the core of the classification, etiological hints can be added as a prefix and the graded variable as suffixes. And example, Helicobacter pylori, pan-gastritis, severely active with mild pan atrophy. And you may see pan-gastritis, gastritis of antrum, gastritis of corpus, and different morphology. Next classification and gradient of gastritis. Update Sydney system. Type of gastritis, etiology, and gastritis synonyms. Non-atrophic, atrophic with 2 variants, and special form with 6 variants. And etiology, first of all, Helicobacter pylori, and after Helicobacter pylori, maybe autoimmune, autoimmunity etiology, dietary, environmental factors, chemical irritation, bile, associated with drugs, associated with radiation, idiopathic, and a lot of etiology factor. In clinical practice, gastritis staging is done using the OAGA staging system for reporting gastric histology. Gastritic staging combines the atrophy score, which is determined by biopsy, and the atrophy topography, which is determined by directed biopsy mapping. Helicobacter-associated chronic gastritis pathophysiology. Helicobacter pylori is the lead cause of the chronic gastritis, peptic ulcer disease, gastric adenocarcinoma, and primary gastric lymphoma. It was described by Marshall and Warren in 1983. Helicobacter pylori is a spiral gram-negative rod that has the ability to colonize and infect the stomach. The lipopolysaccharides of the outer membrane of Helicobacter pylori are a major component of its ability for colonization and persistence. The bacteria survive within the mucosal layer that covers the gastric surface epithelium and the upper portion of the gastric foveal. The infection is usually acquired during childhood. The virulence factor responsible for establishing colonization include urease, fragile hemotaxis system, and adhesins. With increasing antibiotic resistance, this virulence factor provides alternative drug or vaccine target for Helicobacter pylori eradication and prevention. The virulence factor responsible for immune escape help Helicobacter pylori escape from host immune clearance and allow its persistence in the human stomach. Disease induction virulence factor genes. And you may see Helicobacter pylori in microscopy. Helicobacter pylori-associated chronic gastritis progresses according to the following two main topographic patterns, which have different clinical consequences. Antral predominant gastritis. This is characterized by inflammation that is mostly limited to the antrum. Individuals with peptic ulcer usually demonstrate this pattern. And multifocal atrophic gastritis. This is characterized by the involvement of the corpus and gastric atrium with progressive development of gastric atrophy and partial replacement of the gastric glands by intestinal type epithelium. Individuals who develop gastric carcinoma and gastric ulcers usually demonstrate this pattern. And what is autoimmune atrophic gastritis? Autoimmune atrophic gastritis is associated with serum antiparietal and anti-intrinsic factor antibodies. The gastric corpus undergoes progressive atrophy, anti-intrinsic factor deficiency occurs, and patients may develop pernicious anemia. The development of chronic atrophic gastritis limit to corpus fundus mucosa and marked diffuse atrophy of parietal and chief cells characterize autoimmune atrophic gastritis. In addition to hypochlorhydria, autoimmune gastritis is associated with serum antiparietal and anti-intrinsic factor antibodies that cause anti-intrinsic factor deficiency, which in turn causes decreased availability of cobalamin, eventually leading to pernicious anemia in some patients. Some hypochlorhydria induce G cell gastrin produce hyperplasia, leading to the hypergastrionemia. Gastrin exerts a trophic effect of enterochromaffin-like cells and is hypothesized to be one of the mechanisms leading to the development of gastric carcinoid tumors. In autoimmune gastritis, after antibodies are directed against at least 3 antibodies, including anti-intrinsic factor, cytoplasmic, and plasma membrane antigens. There are two types of anti-intrinsic factor antibodies, types 1 and 2. Type 1 antibody prevents the attachment of B12 to anti-intrinsic factor, and type 2 antibody prevents attachment of the vitamin B12 intrinsic factor complex to ileal receptor. T cells, lymphocytes infiltrate the gastric mucosa and contribute to the epithelial cell destruction and result in gastric atrophy. And you may see typical histopathology feature of autoimmune atrophic gastritis. Antral mucosa shows moderate oval hyperplasia, and mucosa of the corpus shows absence of parietal cells, intestinal metaplasia, and pseudo-pyloric metaplasia. Next variant of gastritis, granulomatous gastritis. Is a rare entity. Cases of granulomatous gastritis can be divided into infectious disease, non-infectious disease, and idiopathic, which are observed in approximately 25% of cases. Tuberculosis may affect the stomach and cause gastric granulomas. fungi, including cryptococcus, can also cause case agent granulomatous and necrosis, a finding that is usually observed in patients who are immunosuppressed. Granulomatous gastritis has also been associated with Helicobacter pylori infection. A granuloma is an organized aggregation of combined histiocytic, lymphocytic, and plasmacytic infiltrate. When this organized collection of cells is identified in the stomach, it is referred to granulomatous gastritis. Granulomatous gastritis is a type of chronic gastritis and can be subclassified based on the etiology into infection, non-infections, and idiopathic granulomatous gastritis. Non-infection diseases are the usual cause of chronic granulomatous. This include Crohn's disease, sarcoidosis, isolated granulomatous gastritis. Crohn's disease demonstrates gastric involvement in approximately 33% of the cases. Granulomatous have also been described as associated with gastric malignancies, include carcinoma and malignant lymphoma. Sarcoid-like granulomas may be observed in people who use cocaine, and foreign materials is occasionally observed in the granuloma. Gastritis in patients who are immunosuppressed. Cytomegalovirus infection of the stomach is observed in patients with underlying immunosuppression, but it remains unclear whether cytomegalovirus gastritis promotes the development of the gastric carcinoma. Histologically, a patchy mild inflammatory infiltrate is observed in the lamina propria. Typical intranuclear eosinophilic inclusions and occasionally smaller intracytoplasmic inclusion are present in the gastric epithelial cells and in the endothelial or mesenchymal cells in the lamina propria. Severe necrosis may result in ulceration. All the infections causes of chronic gastritis in immunosuppressed patients include the herpes simplex virus, which causes basophilic intranuclear inclusions in epithelial cells. Mycobacterial infections involving Mycobacterium avium intracellular are characterized by diffuse infiltration of the lamina propria by histiocytes, which rarely form granulomas. Lymphocytic gastritis. Lymphocytic gastritis is a type of chronic gastritis characterized by dense infiltration of the surface and alveolar epithelium by T lymphocytes and associated chronic infiltrates in the lamina propria. Because its histopathology is similar to that of celiac disease, lymphocytic gastritis has been proposed to result from intraluminal antigens. High anti-H Helicobacter pylori antibody titers have been found in patients with lymphocytic gastritis, and in limited studies, the inflammation disappeared after Helicobacter pylori was eradicated. And eosinophilic gastritis. Eosinophilic gastritis can be part of the spectrum eosinophilic gastroenteritis, although the gastric antrum is commonly affected and can cause gastric outlet obstruction. This condition can affect any segment of the gastrointestinal tract and can be segmental. Patients frequently have peripheral blood eosinophilia. In some cases, especially in children, eosinophilic gastroenteritis can result from food allergy, usually to milk or soy protein. Eosinophilic gastroenteritis can also be found in some patients with connective tissue disorders, including scleroderma, polymyositis, and dermatomyositis. And clinical presentation for chronic gastritis. Helicobacter pylori gastritis, which is usually asymptomatic but may manifest in epigastric pain, nausea, vomiting, anorexia, early satiety, or weight loss. Symptoms may occur with the development of complication of chronic Helicobacter pylori gastritis, which include peptic ulcer, gastric adenocarcinoma, and mucosa-associated lymphoid tissue lymphoma. The clinical manifestation of autoimmune gastritis are primarily related to the deficiency in cobalamin, which is not inadequately absorbed because of intrinsic factor deficiency resulting from severe guided parietal cell atrophy. The disease has an insidious onset and progresses slowly. Cobalamin deficiency affects the hematological, gastrointestinal, and neurological system. And you may see common symptoms for chronic gastritis: heaviness, belching, vomiting, flatulence, bloating, and pain. And physical activities. In uncomplicated Helicobacter pylori-associated atrophic gastritis, clinical findings are few and non-specific. Epigastric tenderness may exist if gastric ulcers coexist. Quick positives too may result from acute blood loss. Bad breath and abdominal pain or discomfort may occur with bloating associated with bacterial overgrowth syndrome. Physical findings may result from the development of pernicious anemia and neurological complication in patients with autoimmune atrophic gastritis. With severe cobalamin deficiency, the patient is pale and has slightly icteric skin and eyes. The pulse is rapid and the heart may be enlarged. Auscultation usually reveals a systolic flow movement. And my proposition: watch video with physical examination of patient with gastritis.
Hi there, my name's Andrew, I'm one of the final year medical students. Could I just check your name and date of birth, please?
Yeah, James Alexander, 13th of December 1989.
Nice to meet you, James. Today I've been asked to examine your abdomen. This will involve looking from the end of the bed, feeling various areas of the abdomen, and then listening at the end. Would that be okay?
That sounds fine.
Brilliant. Have you any pain anywhere at all?
No.
And have you got any questions about the exam?
No, not that I can think of.
Okay. Okay, James, we can start the exam now. I'm just going to start by having a look from the end of the bed. James, I'd like to start by looking at your hands. If you could just bring them up in front of you, please. And if you could turn them over. Fantastic. And if you could bring two fingernails together like this for me. Brilliant. You can relax. James, if you could now bring your hands out in front of you and cock your wrist back and keep it there. And relax. You could just lift your right arm up for me. And your left arm. That's fine. James, I'm now going to have a look at your face and eyes. Okay. If you could just look straight ahead for me. I'm now going to pull down on your lower eyelid. And just look down for me. If you could just open your mouth for me. Lift your tongue to the roof of the mouth. That's great. James, if you could now sit forward for me. I'd like to examine for any glands in the neck. I'd now like to more closely inspect the chest. James, we're going to move on to more closely examining your tummy now. For this, I'll need you in a flat position, so I'm just going to lower the bed. If you could just sit up for me. And you can lie back. Now, if you could just put your hands down by your side, I'm just going to more closely inspect your tummy. I'd now like to move on to feel different areas of the tummy. Can I just check before I do that you don't have any pain at all?
No, I don't.
James, I now need to press a little harder. James, could you now take some deep breaths in and out for me? James, I'm now going to tap on your tummy. You could roll onto your right hand side for me, James. and roll back. And I'm just going to listen to your tummy. James, that completes the examination. Thank you very much. You can now get dressed. In summary, I performed an abdominal exam on James, a 27-year-old male. James had no peripheral stigmata of gastrointestinal disease. His abdomen was soft and non-tender, with no masses or organomegaly. On auscultation, he had normal bowel sounds. This was a normal abdominal exam. To complete the exam, I'd like to examine the hernial orifices. I'd also do a digital rectal exam and examination of the external genitalia if indicated.
So, you must provide similar physical examination for all patients with digestive disorders, not only for gastritis, not only for dyspepsia, for all digestive disorders and for every your patients. So, and laboratory studies. A rapid urea test should be done of gastric biopsy tissue. Helicobacter pylori bacterial culture of gastric biopsy tissue is usually performed in the research setting or to access antibiotic susceptibility in patients in whom first-line eradication therapy fails. Atrophic gastritis may be assessed by measuring the ratio of pepsinogen 1 to pepsinogen 2 in the serum. And two variants of pepsinogen are synthesized and secreted by gastric chief cells. After being secreted into the gastric lumen, they are converted into proteolytic active pepsins. The level of pepsinogen 1 in the serum decreases as gastric chief cells are lost during gastric atrophy, resulting in a decreased pepsinogen 1, pepsinogen 2 ratio. Gastric carcinoma occurs especially the intestinal type, usually is associated with severe atrophic gastritis. Measuring of level pepsinogen 1 and pepsinogen 2 and the ratio and the serum is a useful screening for atrophic gastritis and gastric cancer in regions with a high incidence of these diseases. The following test results suggest this diagnosis of autoimmune gastritis. Antiparietal and anti-intrinsic factor antibodies in the serum are achorhydria, both basal and stimulated, and hypergastrinemia. Low serum cobalamin levels, possible abnormal result of Schilling test. And endoscopy. Magnifying endoscopy is helpful for analyzing the subepithelial microvascular architecture, as well as the mucosal surface microstructure without tissue biopsy. Upper gastrointestinal endoscopy is essential for establishing the diagnosis of gastritis. Although some studies have suggested that Helicobacter pylori infection can be determined on the basis of unique endoscopic feature, particularly the presence of antral nodularity. Whether there is specific relation between Helicobacter pylori and microscopic feature remains controversial. The endoscopic findings in chronic Helicobacter pylori infection may include areas of intestinal metaplasia. Multiple biopsy specimens should be obtained. Tissue sampling from the gastric atrium, insula, and corpus is essential to establish the topography of gastritis and to identify atrophy and intestinal metaplasia, which usually is patchy. It is recommended that biopsy samples of the gastric body and those from the antrum and incisure be submitted in separate container for pathological evaluation. Endoscopic findings in granulomatous gastritis include mucosal nodularity with cobalt staining, multiple atro ulcers, line of serpiginous ulceration, second antral folds, antral narrowing, hypoperistalsis, and duodenal strictures. Extensive gastritis involvement may resemble linitis plastica. Endoscopic findings in lymphocytic gastritis include enlarged folds and aptoid erosions with the appearance of small, heaped-up volcano-like mound poked with a central crater. And you may see classification of gastritis in endoscope. Normal view in endoscope, superficial gastritis in endoscope, atrophic gastritis, and intestinal metaplasia. And treatment. Treatment of chronic gastritis can be aimed as a specific etiologic agents, if such as agents is known. Some entities manifested by chronic gastritis don't have well-established treatment protocols. For example, in lymphocytic gastritis, some cases of spontaneous healing have been reported. However, because the disease has a chronic course, treatment is recommended. One of part in treatment, diet. And you may see a gastritis diet chart with amount of calories. You may see food to eat and food to avoid. And pharmacotherapy for Helicobacter pylori. At first, specific recommendations for Helicobacter pylori eradication were limited to peptic ulcer disease. Antibiotics that have proven effective against Helicobacter pylori include clarithromycin, amoxicillin, metronidazole, tetracycline, and furazolidone. One is a version of the traditional bismuth, metronidazole, tetracycline, BMT tribal therapy. 3 different combinations using clarithromycin have been approved, including 2 dual therapies consisting of 500 mg of clarithromycin 3 times daily plus either omeprazole or ranitidine bismuth citrate. The cure rates reported in the packaging literature suggests that the 3 combinations are similarly effective. And clinical experience has shown that the most effective of those regimens is bismuth, metronidazole, tetracycline tribal therapy, followed by ranitidine bismuth citrate plus clarithromycin, as then by omeprazole plus clarithromycin. And tribal therapies and quadral therapies. What is tribal therapies? Twice daily PPI or ranitidine bismuth citrate tribal therapies include the following: lansoprazole, 30 mg, omeprazole 20 mg, or ranitidine bismuth citrate 400 mg orally twice a day. Clarithromycin 500 mg orally twice daily, and amoxicillin 1000 mg or metronidazole 500 mg orally twice a day. And what is it? Quadral therapy. PPI, for example, lansoprazole 30 mg or omeprazole 20 mg orally twice daily. Tetracycline 500 milligram orally 4 times daily. Bismuth subsalicylate 120 milligram orally 4 times daily. Metronidazole 500 milligram orally 3 times daily. Evaluation eradication at least 4 weeks after the beginning of treatment. And information about atrophic gastritis treatment. Once atrophic gastritis is diagnosed, treatment can be directed to eliminate the causal agent, which is a possibility in cases of Helicobacter pylori-associated atrophic gastritis, to correct complication of the disease, especially in patients with autoimmune atrophic gastritis who develop pernicious anemia, to attempt to receive the atrophic gastritis. So, dear student, thank you for your attention. If you have questions, please welcome to comments under this video, and please don't forget write your name and surname and number of your group under this video. See you again. Goodbye.